both of you team. There we go. Thank you very much, Sabine, and to Mustafa, and for inviting me to this session. I'm really honored to be able to speak in front of yourselves. Before I sort of get into things a little bit, I'll make a short introduction about myself, and sort of I'll go through, what the platform is going to be for what I'm going to discuss going forward. Yeah, in terms of the actual layout of the PowerPoint, I was saying to Sabine earlier on that I'd forgotten I had access to Canva, so it's quite a simple looking PowerPoint, but hopefully I'll make up for that with good food for thought going forward. So yeah, I should move on promptly. One thing I would say is that I do speak a little bit fast sometimes. So if you do find that you're missing out on what I'm saying, just raise your hand or poke somebody and I can try and slow down. I'm going to try and turn into the next page. There we go. Yeah, so this is what we should expect from the discussion today. Introduction of, so basically who am I, what we're going to go through, the inverse care law, what digital health inequity looks like, some case studies, a summary at the end, and some questions as well. So as for who am I? Well, I'm a GP. I work primarily out of hours in Birmingham. I graduated in 2010 from the Hull York Medical School, and interestingly enough, I was in Manchester for about 3 or 4 years, where I did my training in Salford Royal, and in Trafford General, and yeah, and so I completed my GP training there, and then I went, after about a year and a bit, I went abroad to work in Saudi Arabia. I worked in the governmental sector in a northern city called Hail, which is like a desert city, and then I also worked in Jeddah, both in the governmental and private sector, mainly around medical education and primary care, sort of training GPs over there. Then I came back to Birmingham, and now primarily I work out of hours. We have the largest out of hours service in Birmingham in the West Midlands, where I work. And working out of hours, allows me during the daytime to do other things that I'm good at, or I'm beginning to get better at, including in digital health, therapeutics, and moaning, which is, I think, probably my chief specialty. Being very frustrated a lot of the time. So yeah, I'm best known for my things on LinkedIn, which I'll discuss in a moment, and also Man Confidence, which is a digital therapeutic startup, which has sort of gone back into stealth mode. I sort of came out of it, or came and introduced it to the world a bit too early, and then now I've gone back and realized I need to do a bit more work before I reintroduce it to the world again. But it's a digital therapeutic, and as you can probably tell by the name, directed towards men. So my rise to fame, that was LinkedIn. And I'm not sure if you haven't connected with me on LinkedIn, please do. Because a lot of my content and a lot of my thoughts and my opinions are on LinkedIn, and also on the Digital Health Critic newsletter, which is again on LinkedIn, but also is on Substack as well, which you can subscribe to, where I give sort of my unadulterated opinions, for better or for worse. It often can be controversial, but I think it's important to be able to raise discussion around digital health, products and things without it being the usual, rainbows and unicorns, and this company raised X million dollars and X million pounds. And I think a recent good example of why it's important to be critical is perhaps Pear Therapeutics, who are a digital therapeutics company in the United States, that at one point were worth over $1 billion, I think, made over $400 million in investments, completely bankrupt, and sold all their assets for $6 million. So a fantastic product that they made, but because of whatever reasons, they were not able to penetrate or understand the market, and a gigantic waste of money, unfortunately, ended up happening as a result. I was on the Health Tech Pigeon podcast, which is run by James Summeroo, who does health technology based marketing and things in London. And that's the episode I was on. If you want to look that up, it's a ET's chronic condition. And alongside that, I do digital health consultancy. I've literally just today formally launched my own website, very cleverly named drjunaidusain.com. But it's I offer digital health consultancy to various companies and individuals, and I'm part of the the Hill, which is Oxford University Hospital's pre-seed program for my digital therapeutic. That's enough about me. I think that just gives you a grasp and an overview about myself and my background, and why I might possibly have an element of not right, but I suppose a right to an extent to be able to give my opinion to some extent or another. At the same time, I'm very open to people taking my opinions and saying, well, I don't agree with that at all, and give me an explanation as to why, or explain why. I think having open discussions in digital health, that can only come from it good. So what you'll find today is my unadulterated, non-diluted, direct opinions. I'm going to give some case studies of real world issues, of real world examples around inequities and around clinicians and their impact on digital health and healthcare more broadly. Now, I'll come on to some controversial, not on purpose, but so often can be felt to be controversial opinions that sometimes might come about when I express my opinions directly. So sometimes I say, well, this product is rubbish, or it's useless, or I don't think it's going to be helpful to anybody, and that can be seen as being quite antagonistic. And I don't mean to do that on purpose. I don't mean to be controversial or to be antagonistic, but I think it's important to be able to at least give an opinion rather than saying, yay, hooray, this is the 7 millionth mental health app that's now come onto the App Store. We need to be able to have a more nuanced discussion about what's being offered and the true benefits of these. What not to expect. Again, so heavily referenced academic piece. I long ago very happily gave away my desire to use Harvard standard referencing and APA and all that, and I will definitely never go back to that. So don't expect a very heavily referenced academic piece of work. At the same time, as you're all aware, digital health is a highly fluid, fast-moving specialty anyway. So you're going to find that often research becomes outdated or loses its validity quite quickly. So even if I was to reference something, it may not necessarily be a value in and of itself anyway. It's also not a one-way street. I think I'm right when I give all my opinions, but it's more me expressing this so that a discussion can be brought around the issue. What it also isn't is the typical ethnographic or social demographic breakdown of inequities. So we all know, Southeast Asian, ethnic minority communities, age, gender, all these things. There's inequity and inequality as well, and all these sorts of things within digital health and healthcare, health technology, and so on. And that's not something that I'm going to be discussing in and of itself as a direct as a direct topic today, but it's going to be but what I'm going to talk about, which is inequity regarding clinicians, will have an impact on that, and hopefully I can demonstrate that in today's talk. So quickly, I'd be very shocked if none of you are aware of the inverse care law. But yeah, people who are most in need of care are least likely to receive it. And does digital health, or can it exacerbate it, or does it exacerbate it sometimes, or is it exacerbated by some products? Yeah, a lot of it's dependent on wealth, on availability to technology, and so on. But like I said, this isn't what I'm primarily talking about. But if we're talking about digital health and inverse care law, inverse care law, is a classic example here: digital exclusion, elderly, disabled, mental health, and so on and so forth. And these sort of inequities and inequalities are well documented, and often this is often we get it through what I call no shit Sherlock type of research, where unfortunately research is produced that just states the obvious. An example, I'm not sure if you can see this, but an example: link found between low nurse staffing and patient death risk. Well, obviously, I know it has to be documented. I know it's someone has to do the research and present it somewhere. But a lot of these inequalities and inequities are very heavily documented. And I myself, my personal perspective, I myself don't see as a clinician myself adding any more value to than what's already been added necessarily. Health tech is often and digital health is often playing catch up. So when we look at various monitoring devices and so on. Often we get the whoops. Our technology doesn't screen for a black person because of the way it doesn't penetrate the skin properly, or there's bias in the learning sort of machine algorithm or whatever the case may be. So often we're playing catch up in digital health and health tech when it comes to minorities. And to be honest, digital health might well level the playing field where you train AI or when you train language learning models and so on appropriately. They may well help to remove some of those inequities and inequalities. A very quick definition before we get into the crux of the talk today. So inequity, this is something that I'm sure you guys know the definition inside out, back to front, but for me it's always confusing. Inequity refers to unfair, avoidable differences arising from poor governance, corruption, or cultural exclusion. Inequality is an uneven distribution of health or healthcare resources. So what I'm talking about here is inequity and not necessarily inequality, which is, although there is some areas where that might overlap a bit. So before I carry on talking, I wanted to ask you guys a question. When I'm mentioning the term digital health inequity for clinicians, what is it that comes to your mind? Is it possible to have some hands up or some opinions by any chance? Or not? Or a chat in the chat box. Yep, Gemma, I got your point. Thank you. That was, I'll come on to that a bit later on as well. So not having access to digital resources. Thank you, Babusha. Some less digitally literate, absolutely. Yeah, true. Some areas commission resources such as some areas don't. That's true. So the points you guys have touched on are an uneven distribution of work to clinicians. I agree. I think these points that you mentioned are all absolutely valid. The things that clinicians are not all capable or comfortable with technology, and these are points I will come on to and discuss as well during the talk. Language accessibility, ADHD, and so on. When obviously these sort of questions are always risky because I might have my own little list, and then other people come with their list, and I'm like, whoops, should I put that in my list as well? But I'm going to show you what I put down, and don't get me wrong, much if not most of what you mentioned in some form or another is a part of this talk today as well. So if I go back into my talk, and I click next, there we go. Okay, so when I think about inequity for clinicians, I think more about the design and build of the actual products in terms of the left out of the design process. And I'll show you some examples in our case studies to show that and its impact. They're often an afterthought in procurement or implementation of decisions or of devices or of apps or whatever the case may be. Clinicians are then forced to fill the gaps manually. So literally, we end up papering the cracks by writing on paper to cover the gaps that are found in technology that's often implemented without clinician input. And the impact of new systems and new pathways on clinicians is not particularly well thought out. Again, I'm going to give lots of examples of that in a second as well. But that's generally what I think of when, alongside the points that you mentioned by yourselves. When we look at how digital health interventions are often created, we tend to, at least what I see or what I tend to see as a clinician is the following. I see a software designer somewhere, teams up with an entrepreneur somewhere, possibly a VC, and then they team up with healthcare management from some organization, plus or minus perhaps a focus group of patients, minus clinicians. Generally, often this tends to be the case, not all the time, but as a general sort of very broad generalization, and that often becomes the digital health intervention or the new electronic patient record or the new remote monitoring system that comes in place. And so what ends up being the effect of this? You get poorly designed products with loads of holes in them, and filling those holes in retrospect it's not always done. So only the companies who are approached to fulfill or fix their problems only do it if it's financially worth it for them and for the healthcare organization. At least to, we all know the staffing crisis and issue in the NHS and healthcare in the UK. Low morale. I used to resent driving to my GP practice, and I knew that as soon as I clicked to put the computer on, it will take me 15 minutes to get from putting the on button to getting actually the EPR to be loaded, which is ridiculous. In this day and age, and it still happens. And then the clunky, I can't do certain things because I have to do it manually, and something that can't be done manually, they have to be done on the system, and it just becomes a mess, and it becomes so challenging when you have a challenging day anyway to then have to fight with the computer system to get out of it what you want, and it could lead to poorer outcomes, or the other side of it could be better outcomes for patients. So sometimes when an digital health intervention is put into place, then the argument is, the paper says, well, we've improved an outcome for the better. That's really that's really good. But my argument would be that often those sorts of things could be even better than what they were had there been more clinician input. Sorry, there's just a couple of things in the chat before I carry on. VC does stand for venture capitalist. Sorry, I do apologize. Legacy software. So by the nature of healthcare, the NHS in particular, when procurement is done and organizations tie themselves into contracts with companies, we're stuck with long contracts. A good example, not directly in digital health, but there was a BT used to have pretty much a monopoly on the landlines for primary care practices and getting into and bringing sort of primary care practices. They were all landlines, and often they would fail. So you'd have days or a day where that would completely go down. Trying to change into a new system, which is like a VoIP, so a voice over internet protocol, I think it is, or program. Trying to transfer from like an landline phone to an internet phone company, in principle, should be straightforward. But if you're tied into a 10-year contract and you're halfway through it, it's extremely expensive to leave that contract with BT and therefore make things better for yourselves and for the patients as a result. So when we think about digital health and interventions and electronic patient records, we have to realize that the effect of this is that clinicians will be stuck with those products, whether they like it or not, for probably a long period of time. Naturally, with that comes preventable waste of resources, sort of time and money. And when we talk about digital health and health technologies, we talk about disruption, but it tends not to be the good type of disruption. The disruption that we like to talk about is how things are changed for the better permanently. But often this is disruption which is just by its nature, makes things often a lot more difficult. So when I look at digital health interventions, this tends to be what happens. Someone somewhere teams up with a tech or software engineer. Often it's a person, not always, with a lived experience or a personal interest in that digital health. Then they decide to go between direct to consumer or business to business in terms of how they want to sell the product. In the latter, they target either the private sector or businesses or the governmental sector, as in the UK, that would be the NHS. They'd have to go through, for the NHS, tick box criteria, which would be MHRA approval, if it's a medical device, for example, any ISO regulation standards, DTAC, and so on. Then they'll go to to events to market it. So conferences, I know in Manchester, the NHS Expo is going on at the moment as well. They'll turn up at these events and get in front of stakeholders. Oops. They'll meet the purse string holders, who are the CCGs, the PCNs. They change their name all the time, ICBs, whatever you want to call them. And usually there'll be non-clinicians or managers. They'll have further meetings, perhaps decide on a pilot, perhaps at that point with the head of department or a senior in a department involved. The product's then accepted or rejected after that period or testing or pilot period. If it's accepted, Joe Block's clinician will now have to use it, whether it's good or bad. And patients will have to use it as well. So that's generally, from the way I see how things go from an idea to being. I mean, it's a very broad generalization, I have to say, but it goes from that one stage to getting down to the Joe Block's clinician. Where things tend to go wrong is around where this conversation is focused on, I suppose, more is around the issue of the Joe Bloggs clinician, or the frontline coalface clinician. Because when you have a head of department who's often a senior head of department in medicine, tend to have a lot more administrative work, less frontline work, more overseeing, less necessarily understanding of the new nuances that are developing within the department, because they're much more involved in management and HR and other things. The question is whether it's the right person or right people who are working with the companies or with the organizations to embed or to bring solutions to the department. So I want to get into this part, which is the case studies. I think this will illustrate more in depth what points I'm trying to make, well, the points I've made generally so far. So this is the case study number 1. It's a new electronic patient record for an out-of-hours provider. Yeah. Does anybody recognize this picture or screen here? What does it remind you of? What is it? You don't have to answer necessarily. Windows, our gem is on old MS Word. Yeah, exactly. Windows 95, which is basically what most of health technology, old EPRs at least, look like. So current problem with this organization, they had a legacy software dating to the early 2000s, looks and feels like Windows 95. So it feels awful from a user experience and user interface point of view. Management looked at it and saw it was an awful and clunky electronic patient record. And they were also found that there was disparity in clinicians in terms of how quickly a clinician would see their patients. So one clinician, for example, or some clinicians would see, I don't know, a patient every 10 minutes or 15 minutes out of hours. Remember, out of hours is not appointment based. You pick a patient off a list and you go through them. So you can spend as much or as little time as possible. Some patients may take 10 minutes, some may take an hour, depending on the nature of their issues. But overall, some clinicians would find spending a lot of time, perhaps twiddling their thumbs in between patients. Some may, see patients very, very quickly, and there was disparity, and the whole system wasn't great. And there's no signs from anywhere from CCG that they were going to pay towards a new system. So the out-of-hours provider piloted a VoIP, which is a voice over internet. It's a digital phone, essentially of sorts, system alongside the electronic patient record that auto selects the next patient. No more cherry picking for doctors. No more doctors saying, I don't want to pick this case because it's a complicated one and it's going to drain me. And you might think, well, do doctors do this? Yes, unfortunately we do. We have our heart sync patients, those who we look at the screen and think, oh my God, Mrs. Bloggs is in again. She's going to spend an hour with me talking about such and such and such and such and so on. So we do basic psychology. Unfortunately, clinicians do cherry pick patients from time to time. They have their preferred ones and non-preferred ones. The problem that came as a result of the electronic patient record was there's a big backlash from clinicians. So many felt that they're now being monitored because the digital system would track how quick some clinicians were and what they were doing and at what point they were ringing the patient, at what point they were not ringing the patient, and so on. Many clinicians left, and of course there were the usual teething issues that come with new systems, like there's internet lag between speaking to the patient and them hearing you and so on. The out-of-hours provider persisted, and overall there was better performance by clinicians, and they were able to monitor better so which clinicians were based where better to get the best out of them. However, there's still ongoing resentment at aspects of the systems where patients don't answer, for example, or the number that's used to auto call the patient is wrong. It has to then be done manually anyway, which, as you remember, manually filling over the cracks. And the crack here is that the patient's number is given to out of hours from 111, but it's incorrect. So you ring the number, the automated system can't get through to them. Now it has to become a manual call anyway. So that's papering over the cracks. And not only that, the system didn't actually fix the electronic patient record, which is still an ongoing project. So now you have two systems that doctors using out of hours. You have the voice operated phone call system, voice over internet, system, and you have a second screen that has an electronic patient record. Generally speaking, when it comes to embedding and new products or digital health products or any product in reality into a system, you're going to get this pathway of initial anger, anxiety, non-acceptance, followed by impatience and trying to work around the system and trying to understand it, to eventually accepting and trying to move forward with it. With this new system, it's in place now. However, there's still cracks that have appeared as a result of a system that's meant to make things better. So coming on here to this point, where do we think from this case study, canvassing your opinion, where are the inequity wins and losses, specifically around clinicians? In this case, where do you think the wins and losses are in this case? I'd be very much grateful for your thoughts. Don't all shout at once. Oh, there we go. Gemma, thank you. Clinicians lose autonomy around the cases they pick. Yep. So that was a big one, because they felt that their professionalism was being questioned, rightly or wrongly. Yep. So no more selective patient. That's the other side of it. So you're democratizing the system. No one's having the ability to choose a very simple case and ignore the more complicated one. Are there any other thoughts, or should I give you some of my thoughts? So some clinicians may actually be better suited in certain cases. Absolutely. So there are, for example, advanced nurse practitioners who are very good with children, or certain ones that are particularly good palliative cases, and that can be lost in the process as well. And sometimes very complex cases require more senior clinicians to make very complex decisions, perhaps around safeguarding of children and so on. Yeah. Absolutely. So yeah, exactly. So Brian, you're completely right. Yeah, some GPs find it very difficult, can be very draining when you're having back-to-back mental health cases, or patients who have drug-seeking behavior who are clearly trying to manipulate their way into getting some drugs from you out of hours. So I'm going to go through some of mine, if that's okay. Here, okay, so for the out-of-hours provider, it was great. They get to monitor clinicians, boost productivity, monetary savings. And for the patients, they're placed in a virtual queue, so they know approximately when to receive a call. But for clinicians, there were a lot of losses. It was a clunky, haphazard implementation with a lot of embedding and teething issues. There's a lot of resentment. There was no frontline clinician involved in the assessment of needs or design. This telephone system was actually one that was taken from was bought in from a company that was placed internationally. So they'd designed it in another country, and then they bought it into the UK and put it into the out of hours center. But there was no frontline clinician involvement in that decision making when they were putting that into place. When it was being embedded, there was limited involvement from clinicians in embedding or implementing the actual system. There was no explanation to the clinicians on why the new system was being implemented. So they were left to make up their own minds as to what was happening. And the organization was reactive to teething issues and the change management process. And I suppose the crux of this was a new electronic patient record or a new way of calling even needed? Or was this a training issue for the clinicians? Could this have been handled a different way? Does everything that doesn't work fully need a digital magic wand to make it into a digital form or into an online form? Or could this have been something that could have been mitigated in a different way potentially? For patients, when the system wasn't working, clinicians would have to, when they ring them, they have to apologize on behalf of the out of hours organization as well. How could this resentment have been mitigated? And there's an easy answer, which is involve clinicians. But I want the more complicated answers. Or any other thoughts?
Can I jump in with a verbal question?
Of course you can, Gemma. Go ahead.
Yeah, I mean, this, as someone who does implementation of tech in the healthcare service, this is like the worst case scenario I've ever seen. Like, it jumps all of the things that good practice would suggest that you do as part of a good tech implementation. I'm actually quite appalled at how bad this particularly was. So I suppose from my perspective, I would be thinking about, you should have involved clinicians from the start. I'm quite surprised that I don't think the procurement process always involves frontline clinicians, which I'm always quite surprised about. It seems to be quite an admin heavy process. But I think even if you've made even if they haven't been involved in the procurement decision, it should still be, okay, you have a steering committee made up of frontline clinicians, managers, the people who are going to be interacting with the software, maybe a risk register around what it is that you're trying to do, training that really highlights why this is being implemented, what's going to be different for you going forward, and also monitoring processes around, is it working, are there any bugs, and what can be done to kind of, fix those going forward. Because yeah, this is quite shocking actually how bad this is.
The generally speaking, the out of hours across the UK, generally speaking, there's a lot of privately run providers. And obviously then with the word private automatically comes the bottom line, which is money, and rightly or wrongly, because they can only do what they can with the money that they're able to. They are providing a service ultimately, but with that obviously do come some shortcuts as well. And yeah, like I said, I mean what just before even getting into digital sort of stuff, what I would have, if it was me, I would have said, right, dear clinicians, we're clearly noting a disparity between some of you guys. Do you know what can we do to fix this? Yeah, and then work off that question rather than we're too possibly afraid to directly confront or talk to the clinicians. Therefore, we're going to force them into a new way of working, perhaps.
Yeah. I mean, the other thing that says, I've also worked in NHS commissioning. So the other thing says to me is that they've done it to save money, but they don't want to admit that they've done it to save money because that's an unpopular thing to say.
Yeah, absolutely. Yeah. Great points, Jim, honestly. Thank you. Where we've got Bibusha, people be used to a particular system they were already using, suddenly use this without training or consulting. There was limited amount of training in terms of a couple of YouTube videos that the clinicians had to watch. But as you all know, YouTube videos are never the same as actually playing about with the product firsthand. So that was the first case. Let's move on to the next one. Okay, this is one I've discussed previously on LinkedIn. So some of you may be familiar with some of this if you have followed it on LinkedIn. But in any case, an AI voice recorder to solve clinician documentation. This seems to be quite in vogue at the moment. So the problem allegedly is a doctor spends a disproportionate amount of time on documentation of notes than speaking with patients. I think somewhere in the United States, it calculated it around, I can't remember what it was, but for every 2 hours of clinical work, there's an hour of admin or something like this. That's in the United States. So Amazon, the big news was Amazon is partnering with 3M, two giants, to try to automate the entire consultation process. So I walk into my consultation room, I meet any of my patients, I'll talk to them, I'll examine them, whatever, and then I move on to the next patient, and the computer does everything seamlessly for me, including perfect documentation. It auto records everything so I can, quote unquote, concentrate on the patient in front of me. It reminds me a bit of Star Trek. I'm not sure how many of you, I'm a Trekkie anyway, but in terms of all the computer, just talk to the computer, it just does everything for you, hypothetically speaking. And it seems to be, on the face of it, win-win. So where do we see the potential winners and losers in this? Can we think around this subject? I know I've had a lot more time than you guys to think around this particular question, but AI or an automated AI process to automate the documentation of clinicians, and then the question around clinician equity. What sort of thoughts come to your mind, if any? I might be asking too vague a question. Feel free to shout out. Oh, this chat box has some comments. It might brilliant. So a common one here is struggle with accents and languages. Yeah, I agree. Any other winners or losers? May record information. That's a really good point, Louise. So domestic violence, for example, there are safeguards in place in current electronic patient records, whereby, because obviously we use the NHS app, you can see your own records now. There are ways that a clinician can hide those from being seen by an external body, or on the NHS app. And obviously, if you've got a domestic violence case or safeguarding case, and you need to document things in the notes, it's not great if the computer does it for you and there's no safeguards around it. Security. If you're able to elaborate on that, Jahida, a little bit, I'd be very grateful on that point. Clinicians use autonomy on what they choose or to include, or the preferred writing style. Yeah, that's a really good point there, Gail.
Can you hear me?
Yes, I can. Hi, Jahida.
Hi. It's about the security, so people may not feel safe. And again, whatever you were mentioning, having the documentation on domestic violence or any other conditions of they don't want to disclose to anyone else. For example, cancer, for example, people don't want their information to be disclosed. Any other things that they're discussing during the consultation. So so this is the main thing. So how can we secure the data and how secure it is? How can you assure the security? We know there's a lot going on with the AI and ethics these days. So that's a big question.
With all the issues with Alexa, I mean, who wants to give their medical details to Amazon and 3M? The next thing you know, you've got recommendations on your Amazon about what, your skin condition or something. It's I know what you mean. I completely agree. Who controls the data, where it goes, and so on. So that's an extremely valid point. If I scroll down, so the winners will be patients, and I'm being a bit sarcastic here. If they're white, middle class, middle of the road, American accent. Most of these, if you Google, some of these AI or dictation softwares, it's a very middle of the road, a very well enunciated accent, often American. And it's great if you've got two middle of the road American accent people in a room talking very clearly, then that's fantastic. You can auto populate the entire consultation. The reality is it's a lot more complicated and complex than it is. So patients or clinicians or patients who don't have the above. Clinicians in the UK come from all over the world. Many have accents from their countries of origin, and they can be penalized as a result. Patients, depends on which part of the country you go to, it's quite normal for a patient to come to me and say, hello chicken, hello cock, hello, these sorts of words, which are normal colloquialisms. God forbid what AI would write in place of these colloquialisms, or what they will work out as a diagnosis as a result. So so it doesn't take into account the sophistication and the level of colloquialism. And often I find, not always, but often I find that some of the American-based companies tend to think of healthcare as being an American problem rather than a global problem at times, and they take that America first approach to it. In any case, is it a real problem for clinicians? Will it actually solve? Will the solution actually, will it actually make a difference? If we look at clinicians now, they touch type. Most of them I touch type. And AI dictation software, which is used often in clinics by clinicians to dictate their own letters, they're pretty good. So when we're talking about auto dictating, an entire consultation, I'd rather have those minute or two to gather my thoughts and write something in a way that I would want to, and remove things that I don't need as part of the consultation. And it's a cathartic and therapeutic process, actually, to some extent, for a clinician to be able to summarize that consultation and think around it in terms of what else that they can, what else we can do. So companies will waste, unfortunately, a lot of money. And I think this is one of those examples where a lot of money is going to be spent on making a very, very, very complicated solution to something that, is very, very complicated. And I don't think the value is there in the way that they think it is. And probably because they haven't really understood what clinicians need. I mean, often it's, clinicians can spend more time with patients. Time with patients doesn't literally mean me speaking to a patient. It means me examining a patient. It means looking at their records. It means looking at their observations. It means me making calculated judgments on all of that. It doesn't mean me, a computer typing for me, therefore I have more time with the patient. And that's not more time with the patient. And even if it is, I have to double check, am I going to trust AI to write everything carefully? And remember, there's medical legal consequences to my consultation. If I make a mistake, for example, and I'm sued, or someone dies as a result, I have to look at those notes and see, 6 months down the road, a year down the road, and say, okay, what did I have? What consultation did I have? Can I trust the AI to be accurate enough for me and under that legal circumstance? I'd rather write it myself, so I know that what I've written. Yeah. So I was going to say, how could these issues be mitigated? I think in this case, it's I think for me, I think this is a vanity project that probably won't go in the direction the companies are thinking or have presented that it will go. The next one, I'm conscious of time a little bit. Case study number 3, dish size, anxiety, stress ball. Okay. The problem, I don't know what the problem is, but I'm going to go into the solution. So the solution by company, I won't name them. It's got a tech ball. I call it a tech ball. It's like a rock type of thing that's made of silicon of some form or another. It's ergonomically designed. It links to an app and expands and contracts to help people when in a panic attack or anxiety-provoking circumstance, encouraging breathing exercises at the rate of contraction and expansion. Yep. The team, the people who made it was a brother and sister team. Oops. Yeah. And this is a quote, and apologies because this is a rather sort of wordy slide, but I want to read it out because I think it's important for me to read it. This is a quote from one of the founders. I am a scientist, but have always been interested in the non-medicinal approaches of mental health issues. More and more people about me started suffering from stress, panic, and anxiety attacks, sleeping disorders, etc. In Asia, people have been practicing them for thousands of years, but over here, breathing exercises used to have a spiritual or floaty vibe around them. I wanted to get rid of that image. No better way to make breathing exercises mainstream than build a cool brand. What Apple did for phones, we want to do for mental health. When people start doing breathing exercises, they often don't know where to start. There are lots of audio guides and smartphone apps available, but for me, those apps have always felt a little contradictory. Our smartphones keep us awake at night. They are the source of heaps of stress. They can't be the solution. I always think of something physical, a device that automatically indicates the right rhythm and the right pace. Laughs, like a cute small animal that you keep in the palm of your hand. Okay. This is there's a lot that I can say about this case, and this is a combination to be honest of health tech and digital health a little bit, because they have an app and they have a tech device there. But breathing techniques are one and only one facet of an extremely complex process in mental health and managing anxiety and panic disorder and so on. It is an aspect in acute panic attacks, but one aspect. And the actual product itself is hugely detached from the realities of clinical, of actual true psychiatry. So this is the problem when we have either lived experience or people who mean well, but may not necessarily understand the nuances that are involved in true clinical, safe clinical practice. Yeah. And there's other sort of examples, many examples of wellness apps, dementia care, and so on. My grandmother had dementia, therefore I think such and such would be excellent. I suffer with depression, therefore I think such and such would be excellent. In principle, I mean, I'm not against, don't get me wrong, this isn't a don't listen to patients or don't listen to lived experience. But this is to understand that lived experience is not necessarily directly congruent or correlates directly with clinical practice. And then these companies enter the realms of medical devices, so software as a medical device and so on, to heavily regulated areas without actually realizing what's going on. And then there becomes an additional problem, which is dodgy research. So you'll find these companies saying, and not just this one company, but many companies saying, so many clinicians found our product to be amazing, or X papers show it's better than placebo. I've put this in here on purpose, not by mistake. I'm not sure if many of you recognize this, but this is Donkey Kong. Okay, so I had a conversation not long ago, and there's a good reason for why I put this in place. if I was to say to you, I had 100 men aged 30 to 45 who were asked me to fill in a PHQ-9, which is a validated questionnaire for mental health. And then I asked them to play half an hour of Donkey Kong and then fill in the same questionnaire and check their mood before and after. I'm not done the research, but I'd be fairly confident that the mood of the men would be better post Donkey Kong than it would be with Donkey Kong, pre Donkey Kong. So does that mean we should now be advocating Donkey Kong as a mental health therapeutic or digital therapeutic because it's better than doing nothing? You could probably argue maybe yes, but I'd say, you see where, without trying to be too cynical, you see where I'm going with the issue in terms of just because it's better than placebo doesn't mean, or just because it has a positive outcome doesn't mean it should be, we should run with it. So coming on to this particular company, there's a lack of clinician in involvement in building it, possibly some manipulation or perhaps marketing around the science of it. This is a very, very important point. Depends who you show your digital health product to. And this touches on what Gemma mentioned earlier on. If you show if you show an iPhone 13 or 14 to someone who's only ever used an old school Nokia, which has the old snake game on it, they're going to be wowed by it, by the new tech or by the new way of doing things. But that's just them saying wow and this looks great. It doesn't necessarily mean a valid clinical opinion. And the other sort of equity point here could be, or inequity point is that skewed clinician judgment, which often can occur, is that due to the ingrained lack of involvement of clinicians within health technology in the first place? Because they're not using and they're not at the forefront of health technologies or health or digital health, then they're being wowed by anything that comes up on a screen and flashes and has bright lights. Okay, I do apologize. I'm going to rattle through quickly because I know that time is an issue and we've got time for questions as well. So case 4, and there's one more case after this. Extremely long waits in emergency departments to see or be treated by a clinician. We all know about this, massive waits. This is a picture from the Independent, 50,000 patients waiting a week for 12 hours in A&E. Okay, so really ridiculous. Solution, the eConsult, which is the name of the company, who's a clinician-led, GP-led company, have an A&E triage system, allows a patient to self-check into A&E, ultimately to have an effective triage. So you go into A&E, type your details in, and then the clinician or the doctors in the other room or nurses in the other room can see, okay, Sabine or Gemma or Mustafa have now entered A&E. This is their problem according to them, and they can immediately start putting a management plan into place for the patient rather than having to wait 4 or 5 hours just to see the doctor, then another hour or two to get the investigations done, then another hour or two to then get the results back and so on. So in this case, it should say case to the 4, not 5. In this case, the winners are, I only see winners. The clinicians get to see, patients' information coming in a way in which they can manage and handle. Patients are able to see doctors quickly. Hospitals are able to redirect patients who are not needing A&E appropriately and quickly. Why is this particular intervention? Why do I think it's good? Before I'm going to the last case, why? And maybe I'm wrong. Are there any inequity issues that I've missed out on in this case? Why is this A&E triage tool? Why as a arguing about clinician inequity, think that this is a good tool for equity and for clinicians and even for patients and hospitals? Does anybody have any thoughts? Absolutely. It's empowerment for everybody. And you can case stream the patients. Right? Someone's got a sticky eye, clearly doesn't need to be in A&E for 12 hours. Why doesn't the nurse send, say the doctor said, pop into the pharmacy, it'll be quicker than staying here for 5 hours waiting to see a doctor. Yeah, absolutely. So it combines so many different things. And yeah, it's interesting because this was actually designed by or led by a clinician who runs eConsult. He's a primary care clinician. The last case, this is case, I might disrupt check-in. Yeah, that's a good point. That's a very good point, Louise. And if patients are drunk, yeah, I think this is the other point, Louise, you're right, in terms of manually cracking over some of the bits of digital health. So yeah, if a patient's drunk or cognitively not quite there, they can't, or perhaps they're blind or unable to use technology, effectively, they still will need to have that manual process available for those who are unable to. So it doesn't solve everything, but I think it makes a big difference. But yeah, that's a very good point. Remote, yes.
Can I suggest we skip over case study 5, and
Yeah.
maybe if there's a concluding slide, and so people can ask questions.
Yes, absolutely.
They have
Yep.
5 minutes left.
Absolutely. Yeah. So does clinician inequity correspond to patient inequity? I'd say yes. And this is a point I made with Sabine before we started, that if a clinician doesn't understand the product, is not involved in its production, and does not have any ownership over it, how can they truly advocate for it for other clinicians or for patients? How can they say this was a really good product that will work for you if they don't have that insight into the product and they're not happy with it? And as I mentioned already, we end up covering those faults manually anyway that occur with it. And I would say if interventions don't help patients, they end up hindering them, hinder clinicians, which will end up hindering patients in different ways. Other quick points on the slide, and this is very quick. So not every clinician input is equal, as I mentioned before. Not everyone has experience in entrepreneurism, entrepreneurial ventures, management, and so on, change management. And I'm wondering why digital health companies are not doing what surgical devices and pharma are doing, which is getting very well ingrained within the health ecosystem. Surgical device companies are stuck by the operating room looking for feedback and advice on their products. Why are digital health companies not doing the same? So in summary, clinicians tend to be forgotten about in various aspects of development and implementation of devices. And we need to ensure that, in my opinion, clinician equity is there in digital health interventions to ensure outcomes for everybody. And we need to allow people to be able to express their opinions openly. Questions, finally.